Welcome to this talk. My name is Dr. Nayaraza, and this is about the applied aspects of pediatric mechanical ventilation. Well, in this particular lecture, I'm not using any PowerPoint slides because I just made this lecture with my handwriting on my iPad, and I find it easy to explain it from my notes rather than making fancy PowerPoint slides and going through that. So I have tried to make it very simplified for you guys so that you can understand in very easy language. And this would cover some of the main applied aspects of pediatric mechanical ventilation. So in this particular lecture, we are going to talk about some of the common diseases or common problems in which the pediatric mechanical ventilation is used. And we will take them one by one, and we will talk about some of the best settings that can be applied in such conditions. So before I start, if you haven't subscribed to my channel, please do subscribe because that helps and it gives me more motivation to make further videos for you people. And if you like my videos, always give me a thumb up and also share it with your friends. And as always, if you have any questions, you can always put your question down in the comment sections below. I always welcome questions and I'm more than happy to answer them. Fine, so let's start. Now the thing is that how do we know what parameters to use for different conditions which would require pediatric mechanical ventilation? Now keep it in mind that in an intensive care setting there could be many diseases or many conditions in which you might have to put the child on ventilator, but in practice we have seen that some of the most common problems that can end up in a child requiring mechanical ventilation is number one, asthma. It's not that common as the other diseases, but still once in a while you can get across a child who has got severe life-threatening asthma, who's not improving on the routine medications, and you have to consider mechanical ventilation. The other condition is acute respiratory distress syndrome. Now, acute respiratory distress syndrome can occur because of any infection or inflammatory condition of the lung. In neonates, it usually occurs because of hyaline membrane disease, which is due to lack of surfactant. In older children, it can be caused by viral pneumonia, it can cause by bacterial pneumonia, or any condition, an inflammatory condition of the lung that eventually leads to widespread inflammation. Then the third thing in which you can require mechanical ventilation for a very critically ill child is in sepsis. For a child who's having like life-threatening sepsis, you might consider mechanical ventilation. And another condition in which sometimes we require mechanical ventilation is status epilepticus. So if a child has got non-stop seizures, you have gone through the routine PALS or APLS algorithms, you have given them 2 doses of benzodiazepine, and you have even given them phenytoin. Obviously, if all these things they are not working, then you have to consider deep sedation, and obviously with that comes the mechanical ventilation. So status epilepticus is another condition in which you would like to consider mechanical ventilation. And last but not the least, trauma, especially head trauma, in which there can be issues with breathing, or you want to give some rest to the organs, and at the same time you want to decrease the brain swelling because there is intracranial hemorrhage or intracranial edema. In that case, you might consider mechanical ventilation. So trauma, especially trauma with the head injuries, you might consider mechanical ventilation. Now let's start with asthma. Now asthma, as you know, is an inflammatory condition of the lungs in which there is mucosal edema, there is obstruction of the lower airways, and there is bronchoconstriction. It's very common in children, and most of the time there is very good treatment for it. So we go according to whether the presentation is mild, is it severe, is it life-threatening. So most of the times either we start with the inhaled beta-2 agonist or nebulized beta-2 agonist. If they're not working, then obviously we can add IV magnesium to it, or sometimes IV salbutamol to it as well. And majority of the kids, I've said majority, 97-98% of the kids with severe asthma, they usually respond to these types of treatments and they get well. Once in a while you might come across an asthmatic child who, despite all these treatments, is not improving. These are the kids who are usually in the high dependency unit or might be in the intensive care setting where you might have to consider mechanical ventilation. Now, asthma becomes very tricky, mechanical ventilation, and I think it is one of those conditions where mechanical ventilation can be very dangerous as well, because it is associated with so many side effects, and even a child can die during the process of intubation. Now, to understand what parameters do we use for intubating a child who has got life-threatening asthma, we need to understand the pathophysiology of asthma. Now, asthma is basically an inflammatory condition in which there is a bronchoconstriction, there are mucosal plugs, but they all lead to overdistension of the alveoli. So basically what is happening in asthma is that the child is not able to completely exhale the air that he's in. So usually there's some form of air trapping. And the thing is that if you ventilate a child who has got already overdistended alveoli, then it can be very dangerous, because if you further extend them, then it would put pressure on the heart. So the mediastinum would be compressed, and the heart, who is already under strain, would not be able to pump enough blood into the system. In other words, the cardiac output would not be enough and the child can crash. So if they are, and that can be further complicated if a child is hypovolemic, because a child who's been breathing very fast would definitely lose some fluids from through insensible losses. And on top of it, there's air trapping. So if there is some form of relative hypovolemia, and on top of it you intubate and you put a lot of air, like overzealous mechanical ventilation, the child can simply crash and can die because of cardiac arrest. So intubation in asthma is very, very dangerous, and it has to be left to the expert. But nevertheless, you have to know the basic principles. And we have seen that in many cases, sometimes in life-threatening conditions, while they are being intubated, they go into a peri-arrest situation or even frank cardiac arrest. So the question comes down to what mode should we use? Like, for example, a child who's got life-threatening asthma, you've tried all the medications, you even tried the IV bronchodilators, but still, like, he's in respiratory failure. SATs are not picking up, acid-base disturbances are there. So the question is, you have intubated, what settings should you use? Now, remember, in asthma, because a child has been working very hard, most of the respiratory muscles are very tight. So it's important to give rest to the respiratory muscles. So the intercostal muscle and the diaphragm need rest. So if you have to give them rest, you need to give the child deep sedation. So the child needs good sedation. Why he needs good sedation? Because the respiratory muscles, which have been working very hard, they require rest. Number two, I told you that there is air trapping in the alveoli. So you need to give time to this air to come out. It's very important that air which is trapped should be allowed to come out. So the inspiratory to expiratory ratio setting is very important. That's why we always start with low tidal volume, because there is already air inside the alveoli. And on top of it, if you are very overzealous with high tidal volumes, you would be putting more air into that, and that simply worsens the condition. So you have to keep low tidal volume, so somewhere between 4 to 6 mils per kg, and this kg is not the real body weight, this is the ideal body weight. So according to the ideal body weight, you take 4 to 6, which is the low tidal volume. And it's also important that you keep a low respiratory rate. Why? Because you have to increase the inspiratory and expiratory ratios. Like the expiratory ratio has to be increased. So obviously when you have to increase, then you have to decrease the respiratory rate. So the respiratory rate in an older child can be set around 12 to 14 per minute, or you can go, if a child is very small, you can go according to whatever is normal for that age bracket. But again, it has to be kept at the lower end of the normal. Why? Because you will be playing around with the inspiratory and expiratory setting, because you don't want extra air to go inside, and already there is air trapping and you do not want to worsen that. So you start with low tidal volumes, 4 to 6 mils per kg ideal body weight. You go with a low respiratory rate for that age bracket, and you have to prolong the IE ratio. Now, normally IE ratio can be set to 1 to 2. Sometimes we even keep it to 1 to 3. But in case of asthmatic patients, it should always be increased because you want more time for expiration, so that the air which is trapped, and on top of it, that the one that you are giving it through mechanical ventilation should come up. So 1 to 4 or 1 to 5, even 1 to 8 ratio can be used, where one part inspiration, 5 parts expiration, 6 part expiration, 7 or 8. And because of that, you are giving enough time to the expiration, your respiratory rate has to come down. Please keep it in mind that there have been various papers which actually have studied the permissive hypercapnia, and there is a school of thought that recommends permissive hypercapnia if you are you're using mechanical ventilation for an asthmatic child. What does that mean? It means that the pH should be kept more than 7.2. Obviously, you are not aiming for the normal pH, but you are keeping it like in a mild acidotic range, so you are keeping it at least greater than 7.2. So we call it permissive hypercapnia, that you're still not blowing off the whole of the carbon dioxide, keeping a little bit of that in, except when the patient let's say goes into arrest and you have recovered via CPR. Sometimes if the child has gone into frank arrest and you had to do the CPR, cardiopulmonary resuscitation, that's the only condition, and if that you have to intubate, then that's one condition where you would not go for permissive hypercapnia, because already the child is acidotic and you just leave it acidotic. It will lead to multi-organ failure, and it can even lead to brain edema, or obviously there will be multiple complications and the child can die. So permissive hypercapnia is generally allowed in asthma when you have mechanically intubated a child. This is according to one school of thought, except when you have recovered the child through CPR. Obviously, when we are intubating a child for when we have to start them on mechanical ventilation and the child is asthmatic, we go through rapid sequence induction. And for rapid sequence induction, it's very important we have to use ketamine. So please keep it in mind, ketamine is the preferred, and with that you can use rocuronium. So rock is the preferred muscle relaxant in case of rapid sequence induction if you are using it in case of an asthmatic child. So remember, ketamine and rocuronium are the preferred in asthmatic as compared to other drugs which can be used for rapid sequence induction or rapid sequence intubation. Now coming down to the mode. So once you have intubated the child, it's also very important that while you are intubating, do not bag the child. Sometimes as we are connecting the circuits and everything, there is tendency to bag and ventilate the child. So do not do, because when you are doing bagging, you are pushing a lot of air inside. So usually in asthmatic kids, it's not recommended to bag them while you have intubated them. So the boards that are kept, usually again it depends on your institutional protocols as well. Some people use pressure control, some people use volume control, but anyhow, assist control is the preferred method. So obviously you are going, in the beginning you have given a child deep sedation, muscles are paralyzed, so obviously the mechanical ventilator has to take over all the respiration. So it would be a sort of continuous mandatory ventilation. And again, as I told you, you can keep the respiratory rate around 10 to 12, sometimes even 14, or whatever is the lower limit for that each bracket. So lower respiratory rate, inspiratory to expiratory, as I told you, normal could be 1 to 2. Here you have to go for more than 1 to 4 or greater than that. And PEEP, that is the positive and expiratory pressure. Obviously, you want to keep the alveoli open, because some of the alveoli would also be collapsed, some would be over distended. So this is a tricky situation, because already you have got air trapping in the alveoli, and if the respiratory rate was not enough, before intubation, the child was breathing hard or something, repeated breaths, where the child is inhaling and the breaths are not coming out, it leads to breath stacking. So that leads to what we call as an auto PEEP or intrinsic PEEP, which you call as IPEEP. So there would be some form of IPEEP as well. So that's why you have to be very careful when you set the positive and expiratory pressure. And the recommended, guideline, they say that you should keep your PEEP around to 60-80% of the intrinsic PEEP, because there would be some form of intrinsic PEEP. So you keep your PEEP setting on the mechanical ventilator around 60 to 80%. So you are not going for a very high PEEP, you are going for a low PEEP. And always, because you have deeply sedated the child, always start with 100% FiO2. 100% oxygen. And obviously every now and then you will be doing the blood gases, and then you will be looking at the oxygen, you'll be looking at the carbon dioxide, and you'll play around with the settings. So you always start with very high FiO2, that is 100% oxygen, and then over a period of time you titrate it down. Obviously it should be at the ideal setting should be at the room air oxygen constant 21%, but obviously a child who needed intubation was not well enough, so you start with very high oxygen concentration and you then titrate it down, depending on the condition of the child. If remember also something, because this is a very treacherous condition, sometimes while you are intubating they might simply crash, or soon after you intubated them they were fine. I mean, obviously they were critically ill, but as soon as you intubated, the child went into cardiac arrest, or soon after you intubated them and you attached the circuits, you played around with the settings, and the child goes into frank cardiac arrest, so they can crash. Now it's important, and you should expect, because you never know, this can happen anytime. So if they crash during or after intubation, first thing is to make sure they are not hypovolemic. So remember, how would you know hypovolemia? Tachycardia, their blood pressure is low, and obviously they're having a lot of insensible losing because of the increased breathing and that thing going on. So insensible losses would make them hypovolemic to some extent. So make sure that they are not hypovolemic. So that's why before starting intubation, make sure they're well hydrated, or you have to start with the IV fluid and make sure they are well hydrated. Now, if they crash while being bagged after intubation, and I told the bagging is not basically recommended when you have intubated them, but let's say you are packing the child initially while you're connecting the circuits and he crashes, the first thing is to stop packing, because you have to give them some period of apnea so that the air comes out. It's basically the air which is putting pressure on the heart and causing cardiac arrest. So again, we have to treat the underlying condition. So you just disconnect the circuit, you let them have some apnea, and sometimes it's called the hugging technique, where you just press the chest so that the chest is compressed and the trapped air comes out. So the key message here is avoided bagging after intubation. So do not bag them once you have intubated. Okay, let the circuit connect. You can give a little bit of apnea and nothing happens. Yes, if the child crashes, you're making sure it's not hypovolemia, it's not air trapping, and the child crashes, or the what you call the end-tidal CO2 is not, then make sure that the child hasn't got pneumothorax. So just get an immediate X-ray to see, or with the clinical examination, just that there are no very hyper resonant nodes in one of the lung fields. So if there is no improvement still, consider what? Pneumothorax. This is very important. Also, when you connected, you set up your parameters and everything, it's most important every now and then you keep an eye on the pressure volume curve and the plateau pressure. So make sure that the pressure volume curve, that the volume of air which is going is not too much, and the pressures are not too high, because if there are too high pressures that are needed, it simply means that there is loss of lung compliance and something is going on. I mean, the child is going downhill. Plateau pressure is also very important, because if the plateau pressure is increasing, it simply means that you can do an inspiratory hold and look at the plateau pressure. So some plateau pressure simply means there's a lot of pressure at the alveoli level, and obviously that is not a good sign. So keep an eye on pressure volume curve and the plateau pressure. So here in this table you can see in the healthy lung, the rate is age appropriate, it changes with the age. The tidal volume is around 5 to 8 cc per kg, and the PEEP is around 3 to 5 centimeter of water, and the IE ratio is around 1 to 1 or 1 to 2. In the pediatric acute respiratory distress syndrome, again you have to keep a low tidal volume, that would be around 3 to 6, 4 to 6, some books say 3 to 6, some say 4 to 6. So the usual strategy is low tidal volume and high PEEP, and you can play around with the inspiratory to expiratory ratio to correct for any hypoxemia, refractory hypoxemia. Fine. Now coming down to the other conditions in which child can require mechanical ventilation, and that is acute respiratory distress syndrome. So acute respiratory distress syndrome in very small children, in neonates or prematures, can occur because of the lack of surfactant. We call it the hyaline membrane disease, and if you do the chest X-ray, complete white wash out of the lungs. Obviously, the treatment here would be giving them surfactant, or antenatally, obviously giving them steroids would also matures the pneumocytes to secrete surfactant as well. But nevertheless, if you come across a condition where the child has got acute respiratory distress syndrome because of surfactant deficiency in neonates, or in even older children, viral pneumonia, COVID, bacterial pneumonia can sometimes end up in acute respiratory distress syndrome, especially if they've got underlying problems like malformed lungs or immunodeficiencies. Again, acute respiratory distress syndrome and sepsis. Sepsis is basically a multi-organ failure because of a dysregulated immune system, and in those cases the settings are more or less the same. So the key here is low tidal volume. So you have to keep low tidal volume. You do not want to give too much air because there will be risk of barotrauma. Already there's a lot of inflammation. The alveoli is very much like, they're friable, they're fragile. So you keep in high PEEP. So you want, because the alveoli is, because there's a lot of edema, surrounding edema. So the alveoli will collapse, whether that's acute respiratory distress syndrome or whether there is sepsis. There will be fluid in the lungs, so that would keep the alveoli collapse. So they are not actually expanding. So we have to recruit the alveoli. So how we do the recruitment? We give a high PEEP. So high PEEP means the lungs are, the alveoli are kept distended by the high pressures, and then you give low tidal volumes so that there is exchange of gases, and the oxygen level and the carbon dioxide levels, they improve. Again, 4 to 6. Again, remember, if you do 4 to 6 mils per kg ideal body weight is the what we call as a low tidal volume, and high PEEPs mean like you can keep it everywhere between 5 to 10, but like usually the higher are, you would be going around 8, 10, sometimes even 12 centimeter of water. And last but not the least, if there is a child with trauma, especially head injury, who has got a low GCS, you want to protect the airways, and at the same time you want to regulate the physiology, then in that case the child has to be mechanically ventilated, especially if they got intracranial bleeds, if they got intracranial or brain edema. So some school of thought say that you might need permissive hypercapnia, because permissive hypercapnia, like if you keep the pH low, what does it lead to? It leads to vasoconstriction, and vasoconstriction helps because when the blood vessels will be constricted, if there is a continuous bleed in the area of the brain, so that bleed would stop. Similarly, edema, vasogenic edema of the brain because of traumatic brain injury, like or diffuse axonal injury, like wherever it happens in car accidents, blunt trauma to the head, and child has got low GCS and he's obtunded or he's comatose. So in that condition, they have to be intubated, they have to be mechanical ventilated. And what we do is usually we do play around with the settings to give them permissive hypercapnia. So we would go for the settings where the carbon dioxide levels would rise. And how can you raise the carbon dioxide levels? Either you can decrease the body temperature, number one, but that's obviously not related with a mechanical ventilator setting. So one thing is like you will make them hypothermic a bit. And number two is that you keep a low respiratory rate, and you keep a low tidal volume. So that way, because your carbon dioxide levels are regulated by minute ventilation, which is tidal volume times respiratory rate. So either you play around with the respiratory rate, or either you play around with the tidal volume. Again, it differs from patient to patient, and again with experience, as are you doing these things, then you would come to a level where you would know, okay, which settings to play around with, and then you are basically an expert then, again with all those experience coming by dealing with all these types of cases. So this was a small video about the applied aspects of pediatric mechanical ventilation, and we have just covered that what settings to use in some of the common conditions in which a child would require mechanical ventilations, what are the issues surrounding mechanical ventilation when we deal with these kids, and how to overcome that. So I hope you have enjoyed this video, you have learned something, and if you've got any questions, if you haven't understood anything, then you can put your question down in the comment section below, and I would try my level best to answer it as soon as possible. So have a good day, stay safe, stay healthy, bye bye.